Very, very lucky today to be joined by Dr. Nathaniel Huppert and Dr. Shubhra Shetty to help us understand better what we're talking about when we talk about the COVID-19 vaccine. I know there are a lot of questions out in the world swirling around information, misinformation, and we are so lucky today to be joined by these two doctors who can help us make sense of it. I think that some of you might have seen the way I wrote this in a memo, and then the paper actually asked us kind of what is the city doing. It was really important to me that instead of just saying everyone should take the vaccine, city employees and the public, that we're providing information so that you can make the decision for yourself. It's critical, I think, as we go into these really difficult public health situations, that we're providing you information as your employer, as we also provide information to the public. It's interesting to sit here and be getting questions from the public all the time, but also we need to make sure that we're giving you information as Scranton City employees. We've asked a lot of you in this last year. We've asked you to be leaders in your families, leaders in your community, in your neighborhoods as we've gone through this. You've done that so well. You were the first to put masks on. You've kept those masks on even when you probably didn't want to. We're so proud and thankful for your leadership within the community, and we're here today to make sure that you have the information that you need to understand the vaccine as the vaccine hopefully starts to roll out further and as many more of us will be eligible. So with that, I mean, I think I would kick it to Dr. Huppert, who is joining us from afar up in New York, and we're so glad that you're here. Thank you.
Turn off my mute. There we go. Hi, thank you very much, Mayor Cognetti. It's really a pleasure to be here. Nice to meet the other members of the group who are putting this on. I'm not in San Francisco, even though that's the background. It's just
I was thinking, like, I don't think he's in San Francisco. I'm pretty sure
that. It's just I like a light background, so this seems to be happy. So I'll try to make my comments positive. Let me just introduce myself briefly. I'm a faculty member at Weill Cornell Medical School. That's Cornell's medical school in New York City on the Upper East Side of Manhattan. I'm mostly a lifelong New Yorker, although I was born upstate. And I work as a hospitalist, mostly doing the overnight shift at Lower Manhattan Hospital, which is in downtown Manhattan, right next to Chinatown. So that's given me a pretty interesting perspective on this whole event all the way from January and February on to now. In addition, I am a public health researcher focusing on public health emergency preparedness and specifically on modeling, using computer models to think about the best response to things like that. So I've had a long career advising the CDC in their division of preparedness and emerging infections, and also for a little while, the hospital preparedness program, which is in Washington in the Department of Health and Human Services. And now, specifically with COVID, in addition to spending a little bit of time on the governor's task force for COVID in New York State back in March, April, and May, I work with this really impressive group of people from around the world on something called the COVID-19 International Modeling Consortium, or the COMO Consortium, which is an unusual approach. It's what we call a participatory modeling approach to getting mathematical models in the hands of people who actually work in the ministries of health or the local departments of health so that they can better project what might happen in the future and use quantitative models to help them understand what's actually going on right now. So I'm the lead for policy for that. It partly uses a hospital model that we created at Cornell back in February and March, and it partly uses a model that was created at Oxford. And it's got 40 different partners around the world. I've been modeling countries as varied as Haiti, helping with Malaysia, and a couple of others. So it's a nice perspective. I was just mentioning to the folks who are organizing this call that this morning I was talking about vaccine hesitancy with 3 different countries, one in Central Asia, one in Southern Asia, and one on the other side of the world. So it's, it's fascinating to get these perspectives on what's going on. Personally, I've been vaccinated as a frontline healthcare provider. I got the Pfizer vaccine, 2 doses. When I first heard about mRNA vaccines, I had lots of questions. I have the luxury of working with a number of basic researchers at Cornell, one of whom, a virologist named Louise Shang, had been using this technology in other fields, not necessarily vaccine fields, for 20 years, and was able to reassure me that he felt that the mRNA vaccine technology was safe. I say that because, I'm the type of person who should know whether or not a vaccine technology is safe. And this is so new that I even felt the need to go to an expert to find out what was the risk, what was the benefit. I was, really fully reassured, and I took it, and had the typical reaction, and have now the reassurance that I probably am a little bit protected. I'm far enough out from my second shot that the protection should be a full strength. The reported protection at full strength means that I'm 95% roughly less likely to get severe COVID if I get infected. And what I'll talk about in a little minute is what the difference is between getting infected and getting COVID, and how the vaccines that are out there affect both. So there's an interesting distinction there. I mention that because a lot of my motivation for getting the vaccine has to do with my own personal life, first of all, my career, and the fact that I come in contact with patients, and I would not want to transmit the virus to the people with whom I'm working if they're not already infected. Second is my family. I come home from work. I try to be as careful as I can be at work. I try to be as careful as I can be when I come home from work. It's funny when things are quiet in the hospital and it's 3 a.m. We talk about what crazy strategies we have for trying to keep our dirty clothes and shoes and other things away from everyone else in the house. So people have come up with all sorts of interesting laundry systems at home. The final thing, of course, is my own health. I mean, it would be nice to not get sick. And one of the scary things about COVID, of course, is that we read stories about people who were otherwise young and healthy and die from this. So I'm sure you know that recently a member of Congress who is in Congress died. Prior to that, a newly elected member actually passed away before entering Congress. So those are, on the political scene, some of the high profile cases. And, in one of those cases, and this is all public knowledge, there was, clearly a serious comorbid condition that put that person at increased risk. But in the other case, it didn't seem that there was one. So one of the scary things about this global pandemic is the uncertainty. Will I get it? If I get it, will I get really sick? Will I pass it on to other people? And I think we have to acknowledge that up front and center. There's a great prior head of the CDC. He was actually just an acting director between Julie Gerberding and Tom Frieden. His name is Rich Besser. He's now the head of the Robert Wood Johnson Foundation in New Jersey. And he's a friend, someone I both worked for and also had the opportunity to present to when he invited one of my engineering colleagues and me down to give the inaugural lecture at this entity that was then called the Coordinating Office of Terrorism Preparedness and Emergency Response, COTPER. We went down there to talk about something that isn't usually a part of public health, which is logistics. It was a 1-hour talk about logistics. And at the end of the talk, people came up to us and said, that was quite interesting. I hadn't really thought about that before, which is something that is pretty consistent and also an indication that doing the hard part of actually things like getting vaccines into people's arms isn't always front and center when you hear either medical or public health people talk about things like this. There's often a little bit of magical thinking that goes on between the, hey, we've produced this wonderful new vaccine, and giving it to people. Anyway, the reason I mentioned Rich is because he has a talk that he gave that's actually part of the CDC's handbook about risk communication. This was the H1N1 pandemic in 2009. He happened to be the acting director when it hit. He mentions three things that I think are really critical. One is acknowledging upfront uncertainty, unknowns, everything that we don't know. We know a tremendous amount about COVID. I mean, I have a colleague who's already published, and I kid you not, 68 papers already about COVID since the start of the pandemic. I mean, that's a lifetime's worth of publications. And it's not just that this colleague is interested in promotion, it's that there's that much knowledge that's being generated about this. And yet, there are so many things we don't know. So just getting back to the vaccine question, how much do vaccines, the currently authorized vaccines, how much do they prevent us from potentially being infected versus getting sick if we are infected? All of the studies that were done to make these approvals, these emergency use authorizations, focused on the second, the latter thing. That is, do people get sick if they're infected? Because that was one of the critical things that the FDA wanted to see. Does this reduce severe illness? The question about transmission is actually much harder to figure out. And the data that we have suggests, but doesn't prove, that the vaccines that are currently in play do reduce your chance of actually getting it, but not by as much as it prevents your chance of getting really sick if you do get it. So we're talking maybe by a third, maybe by a half. And that's very important, but it's not something that is currently completely understood. And that's a problem, because this is one of the first questions that people ask me. So Richard talked about uncertainty. He talked about change, which is the other critical thing to think about in terms of creating a public health awareness campaign, the acknowledgement upfront that everything that we tell you is likely to change. Now, that's not something that the public typically wants to hear from medical experts. They want to know what truth is and what falsehood is. And the idea that there's this huge gray zone in between is kind of troubling. Acknowledging that and saying, you'll hear more from us and our policies will change, potentially gets people used to that sort of framework. And then the final thing is just the fact that that so much of this comes down to the local public health and municipal staff or workers who are interacting, and I should add community workers, leaders of religious organizations and communities, all of these people who not only know the community and typically are part of the community, but also understand how things work. One of the classes I teach is talking about how to use operations research, so this is engineering, for policy. And either the first class or the last class, I show some work from the mid-70s from this organization called RAND, which is one of the big Defense Department think tanks, where this guy named Michael Berman wrote a study that looked at what happens when you implement a policy. And one of the unusual things that he found happens is that people at the local level take that policy and don't simply implement it like a machine, but think about it, consider it, think about whether it's appropriate for their local environment, sometimes modify it. And what's very interesting is that you have not only a change in the policy as it goes down to the local level, but sometimes a change at the local level that then feeds back up to change the policy. And I actually think that this is a really positive, hopeful way to think about this whole vaccination campaign. I would hope that, first of all, we would learn from this. We would learn that thinking through, taking us back to June or May of last year and thinking, how could we have done this better? How could we have better laid the groundwork, knowing that these vaccines were coming? Unfortunately, we didn't know when they were coming, but we knew that they were coming. And so how could we have done this all better? And one of the ways that I think we could have done it better is we could have made sure that the people who were laying out the policy were doing that with input from the people on the ground. I know in many cases with many national organizations that was the case, but I still think that right now we're in the situation where we don't know where the vaccine is. We don't know when it'll be there. I know in New York City, someone who's a software engineer for Airbnb took $50 of his own money and his own programming know-how and created a Twitter account and a web app that does a better job of letting people know when the next opening for an appointment for vaccine is. People have tried to give him money to help support this, and he has a little blurb on his Twitter saying, I don't need any money. If you want to give money, give it to this community organization in Chinatown, which he supports. I mean, it's really amazing that it's come down to this, that we have these people who are creating workarounds for a multi-billion-dollar nationwide vaccine rollout. And that's an indication that something went wrong somewhere. And it's not a blame causing something went wrong necessarily, but it's clear we can do this better. Something went wrong. So making sure, so that it's those three things were Rich's key points. One was we're not sure about much, but we know which way we're walking. The second is we really need to be honest with you that we may change what we say tomorrow, and that's okay. And the third is we need to partner with locals to make sure not only that the message is right, but that the information that we're learning about what's happening on the local level is feeding back up and is changing the policies as they come out. Now, having said all that, I want to just close with two things from these introductory comments, and I'm sure we could get back to some more of this in the question and answer. One is, where's science in all of this? Well, obviously there's all the medical science, but one of the things that I've been working on extensively with my engineering colleagues at Cornell, one is in Singapore at the Singapore University of Technology and Design, one's at San Jose State. We've got people from all over working on this, is that there are sciences outside of medicine that really should be part of the solution here. So for example, one of the things that we've been learning from our engineering modeling is that bigger clinics are much better at achieving population level goals than smaller clinics. Now, I say this knowing that the big innovation of the last couple of weeks is that the government has started to give smaller batches of vaccine to pharmacies that are in local communities. And in some ways, that's a great thing. But what we found is that if you can design an optimal system, it turns out that that is perhaps a component of a larger strategy that really relies on mass vaccination clinics, like the ones that they're producing in Arizona, in LA, at Dodger Stadium. It takes a longer amount of time perhaps and a little bit more effort for people to get to those. But if you do the numbers, it turns out that those will get more of the population vaccinated earlier than other strategies. Of course, the big unknown in that is, will people come? And so I think Dr. Shetty is going to comment on this a little bit, but certainly getting the demand side for these vaccines is more critical than creating the best system for giving the shots. If we create an optimal system for giving the shots and neglect to make sure that people actually come to get the shots, we've failed. So that's all I wanted to say for now, and I'll pass it on to Dr. Shetty.
Great, thank you, Dr. Huppert. So, many of you have been watching the news, reading newspaper accounts as to what's going on with COVID. And I'm going to just do a very quick recap. What we've seen locally is that we saw an increase in the number of cases, hospitalizations, and subsequently deaths probably starting in about late April and May. So in about late April, May, hospitalizations started to go up quite dramatically, and there were a lot of people in the ICU. Things then sort of settled down towards the fall. And as people did better, there was some relaxation perhaps of the guard. And then we saw a post-Thanksgiving spike, surprise, surprise. And then we are just coming towards the end of the post-Christmas New Year spike locally. So there was quite a big spike in cases. And then following that again, hospitalizations and deaths in Lackawanna County as well as in Pennsylvania, which is now starting to slow down. So looking at numbers, so the average of new cases in Lackawanna County yesterday was about 65. Slight increase from the day before, like about a 9% increase from the day before, but overall the trend is downwards. But I just want to point out that there are still new cases coming into the hospital, so sick enough to be hospitalized. There are still patients being admitted to the ICU. So by no means has this sort of gone away. Now, the good news is, as Dr. Huppert mentioned, that vaccine is here. And I want to say I too have received my vaccine. I got the Moderna shots. I got my first shot in like the third week of December, really the week it became available to me. And then I had the second shot, I think it was about 2 weeks ago now. So I think I'm fully immunized at this point. I saw a question in the chat about that. And yes, I did feel sick after the second shot. I would say that the first shot was really, I'm like, yeah, this is nothing. And then the second time around, I think my body was like, oh, I know you, antigen. I'm going to mount my response. And not unexpectedly, fever, some chills, sort of couldn't get warm. Lasted a few hours. I, of course, went to clinic the next day. And then that evening, the second evening, again, I had a bit of a, like a flu-like illness. And then I was fine. I cannot describe to you what a great sense of relief it was to actually receive the shot. My husband is a pulmonary critical care specialist in town, and we have conversations around COVID and what we're seeing in the hospital, what we're seeing in the outpatient all the time. And this is real. It's not like this, nobody's made this up. We're seeing it. We're seeing people having long-term effects from COVID, taking time to recover. And then, of course, there are others who've had the infection, recovered, did fine. We also have medical personnel, colleagues who've gotten extremely ill. It's not common, but it has occurred. And I know of at least one situation where the individual needed to get a lung transplantation as a result of COVID infection without sort of any significant comorbid conditions. So I just want to point that out. So with regards to vaccine, so vaccine is available, but it's hard to get to. You have no idea how many calls I get from people saying, okay, where can I go? So the people who are eager to get it are really, really eager to get it. And my feeling is, as a first round, the people who are eligible, and if they're keen to get it, we should do everything in our power to make sure that they get the vaccine. There's some data suggesting that even one shot probably gives you a pretty decent amount of immunity and antibody levels. And in fact, in some countries, the strategy has become that you get the first shot and then they're delaying the second shot by about 3 months, thinking that you have enough antibodies. So just to address the question that just came up in the chat, if you have COVID, do you have immunity? And the answer is yes, partly. And we probably for some time. So again, to pick off on what Dr. Huppert said, the uncertainty. We don't know everything about this. The current thinking is that after somebody has COVID and recovers, they probably have the neutralizing antibody for a few weeks. Some studies have said 8 weeks, some studies have said a little bit longer. The general thinking is that you should still get vaccinated because it seems like vaccine-induced immunity is probably at a much higher level, but you probably want to wait I don't know, a few weeks, 4 weeks. It's not definitive. So wait for the symptoms to subside from the COVID, and then you should get vaccinated, especially because of some of the variants that are circulating. So if you had that COVID infection and recovered, you probably have antibodies to that strain, but we cannot say whether you have cross immunity to some of the variants. So to combat the variants, it's still recommended to get the vaccine. So you know, what I think we need to work on is streamlining testing for people who need it or should have it, to get the vaccine, to make vaccine availability and access easier and more streamlined, so that we can start to return to life closer to normal. One other question I face a lot is, so you've been vaccinated, I've been vaccinated, do we still need to wear masks? And again, the studies that were done were if the vaccine was good at preventing severe disease or even moderate disease, really did not look at transmissibility. And the worry is that maybe, so I've been vaccinated. The worry is that if I'm exposed to COVID without, say, a mask, God forbid, I could carry the virus in my nose, my nasopharynx, and potentially give it to somebody else. So I need to wear a mask, continue to wear a mask, because I don't want to give it to anybody else, particularly my patients. So that, because we don't know, we don't have the answer. And that is the nature of science. You build upon previous knowledge, you start getting more and more answers, and you sort of put it out there as we have information. One last point I want to make is that I don't want people to feel complacent in any way. There have been some advances in treatment, but they're quite limited. So steroids, there's trials showing that dexamethasone, which is a steroid, can help in moderate to severe disease. There's some work on monoclonal or monoclonal antibodies or antibody cocktails having efficacy to prevent people from getting hospitalized. So, but it's quite limited. Remdesivir, which is an antiviral, again, mild, probably more for mild, moderate disease. Actually, moderate disease decreases duration of illness, but not mortality. So we are far from having great strategies in terms of treatment. I just saw a question pop up about Johnson & Johnson. Yes, once that vaccine hits the market as well, is approved, it should help alleviate the shortages. And it's a one dose, so it's a one-shot vaccine, so a little bit easier in that sense. But let me stop here and just reiterate, if you're eligible and can get the vaccine, I would strongly encourage you to get it. Dr. Huppert's already addressed some of the issues. Vaccine, they've been studied very thoughtfully. They seem to be very safe. We're all lining up to get them. And, I think it's the best way we can think of protecting ourselves and our community. So let me stop there.
Great. Can I just make a couple more points on the basis of what Dr. Shetty just said? So I had a very different vaccine experience, and this may be because throughout February and actually even January, I have the email train to prove it. I kept writing to my old colleagues at CDC. It's interesting timing. My CDC advisory contract was ended in November of 2019. So these are my ex-colleagues now. I was writing to them January, February, saying, I've got patient X. I won't describe it now because this might be public, but I would describe the clinical scenario from Lower Manhattan and say, this person really needs to be tested. And the response typically was, can't do it. Not a direct, no direct connection to Wuhan. Anyway, that's my way of saying we had a lot of cases that seemed to fit the bill. And I'm pretty sure that some of my colleagues were actually infected very early on. I had a really strong reaction to my first dose. Couldn't lift my arm for a couple of days. and was sick enough that I went and got a rapid COVID test because I was concerned. I had been treating patients 5 days before I got my shot. And that was negative. And my second shot, I had no reaction. So my assumption is that my first shot actually was the reactivation of antibodies. And this gets to my second point. When doctors and specialists and scientists say that the antibodies go away after 8 to 10 weeks, that does not at all mean that the immunity goes away. If we had antibodies circulating to every disease that we've ever had a natural, physiological reaction to, we'd just be walking around stuffed full of antibodies. I mean, it's a very inefficient way to think about life. And so the human body, this amazing thing, actually has a system for doing this. These cells recognize something that they want to attack. They build this army of antibodies that can go grab onto, in this case, the spike protein of this little weird ball that's the coronavirus. And then production goes down, but the memory of how to produce those antibodies stays. And that's why these are called memory cells. What it means is that if you then become exposed, the body doesn't have to take this couple of weeks to figure out how to fight this thing. It, not literally, figuratively, opens up the file drawer, pulls out it's this one, and then just feeds it to the machine that produces the antibodies, which are these other cells in the immune system. It's a fascinating system. And immunologists this is their field of work, and they've made incredible strides, even in the last 10 years, in understanding what vaccines do, which brings me to my third point, which is something that I mentioned in an interview back over the summer before we had the vaccines. The question was, what can older people in this country do to protect themselves? Well, there's one thing that I've actually just now, if you want to look it up, a long response to a JAMA article about vitamin D. There's a lot of evidence that vitamin D is very helpful in protecting people against viral diseases. There's very limited evidence about COVID, but there's enough that it's circumstantial, that it helps with almost no downside, that the first thing that I would say is everyone should have a little bit more vitamin D. I mean, all of us living around here are low in vitamin D unless we are breaking all the COVID rules and going to Florida. But the more important thing is any vaccine, especially a handful of vaccines that typically we don't use in this country. So I'm talking about this thing called BCG vaccination, which is against tuberculosis, oral polio vaccination, and a particular type of influenza vaccination that's not very common here, but is very common in Europe. These things activate the body's immune system in such a way that everything gets fought off a little bit better. I mean, it's a very interesting thing about the human body that we rarely get two different viral infections at the same time. And the question is why? I was shouting all summer when people were talking about the twindemic, about influenza and COVID coming at the same time, that was not going to happen. And why was I saying that? Because we saw this with the influenza pandemic in 2009. When the new variant of influenza came, all of the other variants of influenza went away. The body ramping up against one virus protects itself against other viruses. So if there's COVID in the community, there's going to be less influenza. I mean, the other thing, of course, is that we were all wearing masks, which is the best way to prevent influenza anyway. So what this means is any vaccination, not just a COVID vaccine, theoretically, again, very little data about this, but theoretically should provide a little bit of benefit. And actually just yesterday, we got a paper put out there that says that it's possible that we could even, in the setting that Dr. Shetty mentioned, where you get one vaccination and then maybe you have to wait for the second vaccination. Well, some countries are saying, like England, are saying, we're going to just put that off for the time being. It's possible that getting a regular vaccine that you're scheduled for that has nothing to do with COVID could actually help boost your immune system to get a better level of COVID antibodies. So there, again, all of this is mostly speculative. We haven't had the time or the effort put in to do studies of this, but there are lots of ways to improve the body's immune system. This whole question about why some people react to COVID in one way and others react in the other way, this is going to be a field of research, I think, for the next couple of decades. And we're going to learn a lot about the immune system on the basis of this. I just want to mention one last thing, which is, we haven't mentioned it yet, but I think a lot of people are thinking about it. It's this whole notion of herd immunity. I mean, there's been a lot of politics about whether we should just take the gloves off, hands off, and let herd immunity take over. I think there are a lot of misperceptions about what herd immunity means. I just heard this morning that there's a country, actually most of the way around the world from where we are, where the levels of infection in certain cities might already be 90%. The numbers that have been put out there in this country by Tony Fauci and others is that to reach herd immunity, we might need to reach infection levels of between 40 and 60%, some say 70%. If you go by certain numbers, it's all the way up to 80%. By the numbers, Lackawanna County has a little bit more than a 6% definitive case count prevalence. So that means that 6% of your county has been infected. That's nowhere near even the lower levels that people have talked about, but that's probably also inaccurate, because I'm sure in your county, as in New York, as in every other place in the country, we weren't capturing the vast majority of the cases early on. Now, it's probably worse in New York than in Lackawanna because your first wave was a little bit later, and there was more testing happening. But so I think that probably you can add a couple of percentages, but still, that doesn't sound like a lot. What you have to remember is that there are all of the cases that didn't come to medical attention. So it's at least half that are asymptomatic that we weren't going out and finding. So we're talking maybe 20%. And then there are the cases that perhaps went to other counties, who knows? So we've got some rough range of, positive, so COVID positivity of somewhere, let's say between 15 and maybe 30% in your county. That doesn't sound like a lot. If you then look at mortality though, if the per capita mortality in Lackawanna County is 1.8 deaths per 1,000. In New York City, it's between 2.7 and 3.3 per 1,000. If you look worldwide, and especially if you look at the 3,000 counties in the United States, things peter out. I mean, the cases stop growing when you reach somewhere between 1 and 2 deaths per 1,000. And of course, this varies whether you have prisons or long-term care facilities, or a lot of this has to do with the age of the population. Where I'm going with this is, why does it peter out? That's the notion of herd immunity. It peters out, meaning that it stops growing. You don't see the curves going up. But what herd immunity doesn't mean is that it falls like a stone. What herd immunity means is that you've reached the point where you're not overall over the total population continuing to increase. But that could happen at the top of the mountain. And that means that the whole distance that you had to climb to get to the mountain, you now have to come down off of the mountain. Cases will keep coming up, but overall, the number of new cases per case will be less than or equal to 1. Now this, if it's 0.99, that means that it's going to be a long downtrain. What we've seen from approximately January 14th, which I think was when you guys hit peak at about, between 200 and 300 cases that day, is that Lackawanna County has fallen pretty fast. But the same thing happened in New York in the spring. Our cases crashed. I mean, we were at peak the second week of April, and we went below 100 hospitalizations by May 22nd. But then it didn't go all the way down to zero. It stayed at about, between 40 and 80 cases hospitalized a day for the entire summer. And then it crept back up. So this idea of this slow smoldering, I think is very consistent with even reaching herd immunity, because this virus will find an individual and will follow that individual home and will infect anybody in that household or that community to which it can get. And it will keep on doing this. Once we've reached herd immunity, it won't do that more than the cases that are, recovering. And so overall, it will go down. But it's not like herd immunity is a magical stop to the whole outbreak. This, I think, is the most important reason why vaccination is critical, not only for you, but also for the community. Because the sooner that we can get to the point where the next individual who, if you think about the virus as a willful being, the next individual that this little virus wants to go infect is protected, even a little bit, the quicker that slow smoldering in the community will go away, and the quicker we can all get back to normal. Sorry, that was pretty long-winded, but I wanted to just get that out there.
No, it's really interesting because the herd immunity piece is really confusing, and it has been this entire time. It's also, obviously been used as a talking point against vaccinations and things like that. So it's very important to hear that from you, doctor. I wanted to make sure we got all the questions from the chat. Cecilia's asking if the vaccine has been rolled out for children under 12. I don't think
Not
so.
yet, no, not yet. So we're still at, the frontline workers, health workers, police, etc. And now sort of the eligible over 65s, or if people have comorbid conditions. So in Pennsylvania, that's the rollout. That's where the rollout is happening at this point. Kids, interestingly, children under the age of 10 seem to have a quite different, much more overall benign course, unless they have health, other health issues. Do we know how long the vaccine is effective for? Great question. We do not have the answer yet. We hope for at least a year, maybe two, but I think the studies will show us how long the immunity lasts, and maybe we'll need another booster, but we don't know the answer. Long enough is what I'd like to think.
Yeah.
So I don't see any other questions in the chat, but just in case any of our other attendees either didn't have access to the chat or weren't sure how to use it, I just want to check in and make sure no one else has a question with our audience, and it doesn't look like it. So, okay, thanks. I just wanted to make sure everyone had an opportunity.
Great.
Mayor Cognetti?
Yeah, I'll just add. So what's in the long-term future? What does 2022 look like? Is this going to become part of our annual vaccination? Are we going to have the same requirement as with flu vaccination, where if you don't get your annual COVID vaccination, you have to wear a mask, that sort of thing? That's certainly a possibility. Before this event, we had 4 COVID viruses, 4 strains of coronavirus. Sorry, I should be clear with my language. There were 4 strains of coronavirus that were part of the standard viral panel that we gave to patients. So this, ranges from influenza to rhinovirus, and there were 4 coronaviruses on it. It's possible that this will become one of those. A lot of that has to do with these strange new strains that people have heard about. I think we probably should mention something more about that before we end. So there are two that people have been talking about quite a bit. One is the first one that was discovered in the UK. It's the B117 strain, which if you look at the curve in the UK, there was their spring wave and then their fall wave and then this spike. And there's a lot of sense that this variant contributed to this very large spike that occurred very quickly, large upswing, large downswing. There have been many variants of this particular coronavirus, the SARS-CoV-2. I have mathematical biology friends, it's good to have those, by the way, who've been analyzing this and are less concerned about its long-term impact than the headlines would have you believe, because it's following a similar trajectory as many of these variants, which is that it causes a lot of trouble early on, and then it just sort of fades away. Time will tell. The more concerning one is the South African variant, which has cropped up in a couple of places in the US, especially I think there was a headline a couple of days ago about it being in California. The reason why that one's more worrisome is that it seems that the vaccines that are available are less effective against that. Again, when I say less effective, I mean less likely to protect you from having COVID rather than being infected with SARS-CoV-2, having severe disease. And so it's unclear whether anything has changed regarding the transmission. Now, the story about whether these variants are truly, something that we need to worry about on a long-term basis, it probably will be told over the next couple of months. There are a lot of studies going on about them. The CDC recently came out with a very worrisome model that suggested that the variants would take over and would be very dominant. There were a lot of very smart people who went into that model, but it was assembled quite quickly, and I'm not sure that that's the final word on it. So the variants will help to determine how bad this is by the end of this year and certainly into next year. One of the things that public health folks, I'm sure like many of you, know is that we wouldn't be in this situation with all of these variants coming up if we had done a better job globally at tamping this down better at the beginning. I mean, having this thing essentially replicate itself 100 million times, times all the times that it replicates inside a human body. So we're probably talking trillions, if not more, opportunities for this virus to change. That's just given it the time to figure out a way to be worse. And also to be less damaging. Variants don't always go in the direction of being more severe. So I think there's a lot of unknown. My guess is that that this will become a vaccine that we will either need or have the opportunity to take multiple times in our lifetime. And that unfortunately, as we encroach on the natural world more and more, which is where these emergent viruses get their start typically, that this is going to not be our only episode of a global pandemic in our lifetimes. I mean, we've already had two. H1N1 turned out to be severe in some cases, but certainly was not the pandemic that the US had prepared for. Coronavirus did not take any coronavirus scientists by surprise. They were all screaming about this ever since SARS first showed its head in 2003. And now, of course, we're all listening. But there are other viruses out there that a lot of very smart people are very concerned about. Nipah virus is perhaps the main one. If you saw the movie Contagion, it was loosely based on a Nipah virus outbreak. So there are, there's still a lot of work to do. This is one battle in a very long chess game between humans and the natural world, which has no malice. It just does this, and we have to deal with it.
Yeah, it's really helpful to hear that it's something we might have to take multiple times. I think with all of this, right? And Dr. Huppert, I think we talked about this while we were chatting offline, and I forgot to say here with everyone, Dr. Huppert was on the phone with us in March of 2020 as we were trying to compile all this, and was just instrumental in us understanding what we were up against. So to close out, I think with you saying that we're probably going to need to take this vaccine multiple times, that's just really helpful. I'd rather know than not know. And it's better to get this information on the front end and brace ourselves. We know we can all be very resilient after this last year. So it's good to have the facts and the truth. And I really, really appreciate it so much. I appreciated you back in March of 2020, Dr. Shetty. You've been by my side through this entire time as we've tried to keep people safe and try to get information out. So I'm deeply indebted to both of you for everything for this last year. And I really appreciate your time today. It's so helpful, not just today with this group, but we'll be sharing this with the rest of our employees that weren't able to join. And if it's all right with you, hopefully we can share this with the public as well.
Sure. It's been a pleasure to be of service, and thank you for calling back in March. I've probably, certainly never before, and probably never again will have the opportunity to make a decision about what to do with the St. Patrick's Day parade. So
there you go.
I'm sorry that I had to make the decision that I did, but I'm glad that it potentially helped. So thanks so much.
We know Scranton there's always something different, and that was ours. But it helped. I think that because we had to make that decision, that actually helped bring home to the whole city how serious this was, right? If we were going to have to cancel, and the parade committee was great, if we're going to have to cancel the biggest event of our whole year, both culturally and economically, then it must be serious. So I really actually think it started us off on the right foot, where everyone here took it seriously. And I hope that the numbers kind of bear that out, and that we continue to do what we need to do. So thank you all so much. Valerie, thanks for being with us today. So appreciate your time as well.
Okay,
Welcome.
thanks so much.
Thank you.
Thank you. Bye-bye.
Thanks, everyone.